Hi, I'm Dr. David Rubin from the University of Chicago Medicine, where I'm Chief of the Section of Gastroenterology, Hepatology, and Nutrition. Welcome to Expert Perspectives. We're in Chicago today for the 6th CME meeting called Mastering the Clinical Challenges and Emerging Therapies in Inflammatory Bowel Disease. I'm delighted to have one of our faculty from this meeting joining me to discuss the highlights from this meeting for our clinical and community-based colleagues. Joining me is Dr. Asher Kornbluth, who is a clinical professor of medicine from the Mount Sinai School of Medicine in New York City. Welcome, Asher.
Thanks, Dave, for having me.
Sure. So this is an exciting meeting because we have a lot of new things we're talking about. Even since DDW, I think there's new information for our colleagues. This morning we talked a little bit about some of the changing endpoints in IBD. So in your own practice, why don't you share with our audience how you're incorporating some of these new endpoints like objective markers or even patient-reported outcomes?
So I think in a sense we're using this term patient-reported outcomes a lot more than we used to, but it's essentially what we've been doing in practice for as long as we know about IBD. We ask the patients, how are you feeling? Ulcerative colitis, how much diarrhea? How much are you bleeding? We go beyond the Mayo score. We ask you about urgency, which is a big fear factor for the patients. If they had incontinence once in their life, it forever dominates their thinking, waking up in the middle of the night. So we look at patient-reported outcomes, in fact, much more thoroughly than we've had in the standard Mayo Clinic score. But we've learned, as you know, and we've now accepted for years that mucosal healing is no longer something debatable. Mucosal healing is not only a good thing, it's something we really should be shooting for in all our patients. Decreasing recurrence, decreasing hospitalization, decreasing colectomy, which is not to say every patient who has ulcerative colitis who goes into a full clinical remission needs a sigmoidoscopy.
Absolutely.
But if the patient is sort of hovering, doing a sigmoidoscopy to help guide us in terms of mucosal healing is very worthwhile, I think.
Yes, and in my presentation this morning we talked about this emerging treating to achieve targets. And I emphasized that the target isn't always the same for every patient. For some people, it might be important to get them as close to a healed bowel as possible, but for others, that's not practical or necessary, as you said. For instance, the target may be something else, like a biological marker. The CRP is normalized, or we're watching a patient in a monitoring phase after they've had surgery, for instance, to prevent recurrence. So there's a bunch of new things that are starting to come down the pike. I've been particularly interested in emphasizing with our colleagues the importance of disease monitoring, both to achieve the target, but on the other side, which is what I'd like you to comment on, which is how do you monitor after you have a patient in remission, whether it's clinical remission or some other more durable remission like a healed bowel. What is your usual practice for that stable patient?
So I have a standard sort of revisit protocol. Patients who are on combination therapy, for instance, I see every 3 months arbitrarily. I pick that number. Monotherapy with the biologic every 4 months. If they've been stable for a long time on monotherapy with 6-MP, I say every 6 months. But obviously, if they're flaring at all, much sooner to bring them in. And I'm much more likely than rather just say, how are you doing? Check the CRP, which we have to remember will never be elevated, and about 20% of patients just don't make CRP, but relying more and more on fecal calprotectin, which is obviously non-invasive and is usually a very good marker and something to follow in a serial fashion that will eliminate the need for more invasive, more costly evaluations on an ongoing basis.
So we're doing the same thing. And I think an important message is if you have an elevated CRP in your Crohn's patient, and now there's a little work in ulcerative colitis that suggests the same, don't ignore it. This is a setup for a patient who's likely to have a problem down the road. What about fecal calprotectin? So what's your threshold value, and how do you explain that to a patient, and what are you doing?
So the cutoff values are sort of a moving target. Typically, I look at what the lab considers their normal, knowing that might not be the best evidence-based approach. But I think each patient, if they start off high and I see it coming down, I'm reassured. Flip side of that, I see a patient who has mild symptoms. I've brought them back to calprotectin. The CRP is mildly elevated. I might make a change in their therapy. I might not if the patient looks clinically okay, but I see those markers continue to go up. Then I'm obviously going to be much more aggressive in terms of monitoring, reevaluating to see what's happening.
Yeah, and one of the things that we also talked about during that discussion was how do you monitor a patient who has either stopped one of their therapies because they needed to or because we made a conscious decision to do that, or even if you've reduced the dose of a therapy because they're in a stable monitoring phase, and how you follow them out. And I think that that hasn't been well defined yet, but in general we recognize periodic measurements and routine visits when they're stable, as opposed to waiting for crisis management, which is always too late. And that's a big change in our field, because a lot of our colleagues are still treating patients based on when they call or when they're having problems.
Right. So the first question is, this is also something now is being studied prospectively, as you know, is who can you stop therapy? Because from day one, the second question patients ask is after, why do I have to be on the medication, is when can I stop it? And so finally we have some decent information about the kind of patients that we can withdraw therapy. And frankly, if patients are on combination therapy, I now make a strong case that they should be stopping the thiopurine, which is sort of a novel concept because we've been using thiopurines for 15 years and anti-TNFs for far less. But we know now that clearly the anti-TNFs probably have significantly lesser lymphoma risk and clearly more effective. So if I want to go to monotherapy from combo, I'll stop the thiopurine. It's rare that I've had a patient who's been sick enough to need combination therapy, or even monotherapy with one of these two agents, that I'll leave on nothing. But if they're on combo and I'll stop something, that's a patient that I will ascertain 100% before I entertain with that patient stopping the therapy is that they're in a true clinical and biological remission. Not that they feel, if they have ulcerative colitis, their mucosa is normal, their histology is normal. If they have Crohn's disease, an ileocolonoscopy, and cross-sectional imaging, and all these patients obviously CRP, albumins, fecal calprotectins. And if I stop something, as we discussed very nicely this morning, they'll keep coming back for regular interval checks clinically, as well as hard biological markers, the simplest and least expensive being CRP and calpros.
So our approach is similar in Chicago, and I don't leave patients on nothing, but when we de-escalate, we talk about monitoring carefully. I think some of the more recent studies do show what you said, which is that the TNF inhibitors appear not to increase the risk of lymphoma above what we know in IBD, which is that it's not elevated in the general population of patients. And I've moved much more to using methotrexate, especially in my male patients, but even in my female patients with appropriate precautions. And we're learning a lot more about how to use that therapy as a concomitant drug. Are you using metho?
More in Crohn's. I haven't really wanted to use it in UC because of the paucity of its primary role as a therapy in itself for ulcerative colitis, where we know in Crohn's disease that it does have therapeutic benefit in and of itself. But obviously with the young males and the risk of hepatosplenic T-cell lymphoma, albeit as rare as it is obviously extraordinarily frightening when you say to the patient or their mom or dad that if it does happen, however rare, it's universally fatal. The patient bolts for the door and you say, well, one option we have is methotrexate to prevent antibody formation to your anti-TNF.
Right, as a combo therapy.
Right.
And you made a little bit reference just now to the fact that there was actually this trial presented at DDW from Europe in which methotrexate 25 milligrams subcutaneously did not work in ulcerative colitis. Right. So specific in the UC population, until we know anything else from other trials, it would be to prevent antibody formation or to enhance the pharmacodynamics of the TNF inhibitors. Great. So let's shift gears now and talk about what you presented, which was therapies beyond anti-TNF. So you gave a beautiful presentation this morning on anti-integrin therapy, and specifically the newest drug available to us in that category, which is vedolizumab. How are you using that in your practice?
So clearly, patients who have need another mechanism of action, different class of therapy, when they have a secondary loss of response to an anti-TNF with adequate anti-TNF level, or obviously in the patient who is a primary non-responder to an anti-TNF, it's a very easy call on those decisions, whether it's UC or Crohn's, where it works far less rapidly and probably less effectively, to move to vedolizumab. The question that we are still evolving is which patient should we use vedolizumab prior to an anti-TNF. I think in Crohn's, I'll probably not do that at all, based on the data. I'm very pleased with how it looks for maintenance therapy. For induction therapy, it just takes quite some time to work. If I'm going to use Vedo as the first-line therapy, I'll probably jumpstart the patient with prednisone or any other form of steroid. In ulcerative colitis, it's certainly going to move quickly, I think, to perhaps frog leap over the anti-TNFs because, frankly, its safety profile is so good.
We've presented at DDW and we also presented at ECHO our experience with vedolizumab since its approval in the US. And in a large number of patients with Crohn's, what we did in our real-world assessment is we looked at a week 14 outcome. So you'll recall the clinical trial that led to its FDA approval was looking at a week 6 outcome, which everyone agreed was probably too soon. When we get out to week 14, our response and remission rates we're up to 200 patients now, looks pretty similar to UC. So I agree that we need some kind of bridge strategy to help patients induce a bit better, but we've been enthusiastic about it. On the other hand, I agree from a strictly mechanistic point of view and understanding that Crohn's is more of a systemic disease, or at least more full thickness and all the other things we think about. I still like to use anti-TNF for my sicker Crohn's patients, no doubt about it. But overall, our safety of this therapy looks really favorable and seems to be holding up. And I think that it is a really important new addition to what we're using. You mentioned a few other therapies towards the end of your presentation. What's coming? What can our colleagues look forward to?
Well, we have more drugs in phase 3 trials now than we've probably had in the last 50 years combined, or at least more promising phase 3 drugs, both biologics as well as, quote, small molecules, oral therapies. The one that's furthest along is obviously ustekinumab, which is already on the market for psoriasis. Looked very promising in the earlier trials. Is probably going to be completing or might already have completed enrollment for its pivotal trials. That's going to be an effective therapy. Where it fits in terms of perhaps prior to anti-TNFs, perhaps after TNFs, the speed with which it has its onset in Crohn's disease, only time will tell. There are other drugs that are or have already completed their pivotal trials in ulcerative colitis. Tofacitinib, also on the market already for rheumatoid arthritis. Pill twice a day. If that turns out to be effective or as nearly as effective as the IV therapies, it might very well be a game changer. Albeit, even though it's a pill, it still has potentially significant toxicity and costs that will probably rival the anti-TNFs.
Yeah. Well, it's an exciting time, and of course now we're going to have to figure out in whom do we use these therapies. Can we identify the right patients who are going to respond and those who wouldn't respond, and how do we afford everything? So that's a big challenge, right?
Yeah, absolutely. And it's going to make the decision making a lot more complex based upon different mechanisms of action. And unfortunately, we don't have markers now that will tell us, is this a patient who's TNF driven? Is this a patient who's interleukin 12-23 driven? Is this Janus kinase inhibitor driven? We just don't know yet. And it's probably going to be years before we could identify proactively which patients should get which drug.
Yeah, and unfortunately true. Not only from the standpoint of our colleagues and the way they use therapies, where they just add the latest drug to the list and wait until the patient's gone through everything else, but very challenging are payers, so insurance companies not letting us use a new drug because they have a contract that exists already with the biggest anti-TNF that's available or whatever it might be. So we need to be pushing back and trying to advocate for our patients, but the best way to do that is going to be to have the data that guide us.
Right. And hopefully the payers will be enlightened enough to look at this data and not just say, well, my given patient's only going to be on my payroll, so to speak, for the next 2 years, so I don't care about the 5-year and 10-year outcomes. So if they have a very short-lived outlook, it might really hamper our ability to properly treat these patients with these long chronic diseases.
Well, and there are some very obvious today things that payers should know, like not requiring that we go through more than one drug in a class before we move on to a different mechanism. And the CCFA and others are working on that, and I would encourage all our colleagues to try to push back as well. So there are a couple of case discussions that we have both this morning and in the later part of the program related to topics that are challenging to the clinician. Let's talk about C. difficile. So what's it like in New York City and at the Mount Sinai Hospital, and do you guys feel that there's a rise in C. diff among your patients, and how are you treating them?
Yeah, so without question, at Mount Sinai, New York City, it's no different than everywhere else in the country, in that we're seeing more frequent C. diff, more aggressive C. diff, more difficult to clear C. diff, and colitis or Crohn's patients who get C. diff having far more difficult time in terms of clearing and improving their underlying colitis. You have a lot of data on your own in terms of fecal transplants, in terms of IBD. Ari Greenspan, a young faculty member at Sinai, is looking at it, just starting to do a controlled trial looking at fecal transplants in IBD without C. diff, but clearly the success rates of 90+% success and clearance of C. diff with fecal transplant is very striking and optimistic. We don't go straight to it. Obviously, our choice of drug when the patient has ongoing significant colitis has been Vanco rather than Flagyl.
And for how long?
That's a good question, and we don't have a good answer, and you can't tell after 14 days if the patient has truly cleared their C. diff. And frankly, if the patient has had ongoing significant colitis, I'll give them a 28-day course, not knowing that that's the right answer and not being able to tell until the patient actually gets better.
Yeah, my approach is the same. Although I don't even do 14 days anymore. So anyone with IBD who has a Clostridium difficile infection, or at least we think they do, we treat for 30 days with vancomycin orally. If they fail 2 cycles of therapy, then we consider fecal transplant, but I want to emphasize that that has not demonstrated improvement in the IBD in these patients. Now there's a very important baseline problem that we don't quite understand yet, which is the colonization rate of C. diff in IBD. And we have a fellow now who's actually doing that. So in all of our clinic patients walking in the door who are otherwise well, he's been swabbing them from below and trying to get some baseline so we can actually look at risk factors. And maybe in the future we can do more prevention strategies.
Yes, we need easy to tolerate and less expensive drugs than the metronidazole and the vancomycin to enable that. But I think given how difficult it is to have a patient improve once they have C. diff, that's a great approach at looking at this problem.
Yeah, so hopefully we'll have some data for that soon. We're also going to talk about, or we will have talked about by the time this airs, medical marijuana. It's not legal in New York, is it?
It was approved by the State Assembly. It has not been made clinically available yet. Across the George Washington Bridge, Lincoln Tunnel and Holland Tunnel in New Jersey, it's been available for some time now.
Okay, so in Illinois it's legal but not available yet as well. So I'm sure you have patients asking about it all the time, just like I do. What are you telling them?
Frankly, even before the few trials came out, where in Crohn's disease, if you're using a subjective index, patients got better compared to placebo. They get high, they feel better. It's sort of intuitive. When you look at objective markers, as you know, they didn't seem to get as well. Interestingly, I've had for decades patients with Crohn's but not UC having no history of drug-seeking behavior, having no tendency to smoke marijuana as a rule, tell me that just a couple of puffs of marijuana is the best thing and maybe the only thing for their abdominal pain, obviously to improve their appetite. And I've never seen it UC, and I've seen it work really well in many of my patients. I can't say that I've used it myself as a recommendation in lieu of medical therapy, but I certainly will tell the patient who asks about it that it might be worth a try.
So in Illinois, Crohn's is an acceptable diagnosis for obtaining medical marijuana in controlled doses, but UC is not on that list. And so it's probably based on some similar comments or recommendations from people around. And so I think that that's important. I think emphasizing to patients that this can improve symptoms but not inflammation is a key message in doing that. So don't manage their active inflammatory disease by agreeing to cannabidiol substitutes or derivatives. The last topic I wanted to touch on before we wrap is this very important topic that we're going to talk more about in our field and we need to be thinking more about, which is how do we incorporate more of a psychological assessment and pain management approach to our patients. So you're a really experienced clinician. Do you routinely screen for anxiety and depression among your patients, and do you have colleagues you refer to, and how do you deal with this?
So I don't have a questionnaire, obviously, but I pay enough time and attention to get a sense of whether the patient is suffering. I have a low threshold to suggest that they seek either talk therapy or medical treatment of their anxiety, depression, or combination. It sometimes takes quite a bit of convincing, even in New York, the home of neuroses and psychoanalysis and psychopharmacology. A lot of patients,
Woody Allen.
yeah, and Woody Allen. A lot of people still attach it with a stigma. but I think it's extraordinarily important to address it. These patients are often crippled not so much by their mild or moderate disease activity, but by their anxiety and depression.
Yeah, so our other faculty member, Eva Sigathy from Pittsburgh, is really an expert in this, and we're grateful that she's devoted her career to our patient population, because we're learning a lot more about how important that link between their psychological well-being and their physical or gut symptoms is, and understanding how to control both and manage them appropriately is really an important area that we can't ignore. And often in a busy clinical practice, when we're focused on CRP and fecal calprotectin and when the next colonoscopy is, we can't get to these other issues which are so important. So I think that that's a major message from this meeting. Well, I want to thank you for discussing this with me today. I want to thank you all for logging on for expert perspectives from the Mastering Clinical Challenges and Emerging Therapies in IBD here in Chicago. And I want to tell you that the Chicago meeting has become a great meeting. It's standing room only this year, and the weather is beautiful, the restaurants are great, and I hope that you'll all join us next year for the next one. Thank you very much.
Thank you, Dave.